Well, hello, everybody, and welcome back to the Health Systems CXO podcast. My name's Robin Brand. I serve as VP of Industry Insights here at the Health Management Academy. And I'm very, very excited about our episode today. I am joined by Dan Liljenquist, Chief Strategy Officer at Intermountain Health. I'm sure he needs no introduction to most of you, but Dan, would love for you to just kind of give an overview of, your role and what you're working on now. And then we'll get into it.
Great, Robin. So good to be with you. And I'm just honored that the Health Management Academy is interested in this subject today. I'm Dan Liljenquist. I'm the Chief Strategy Officer at Intermountain Health, and I've been at Intermountain 13 years and very excited. You, of course, know Intermountain. We're a large integrated delivery system, nonprofit system headquartered in Salt Lake City, Utah, but we operate in 6 states. And we are involved in urban centers and rural, and we've got a lot of experience in rural, and that's what we'll be talking about today. But I'm delighted to be with you.
Perfect. Well, yeah, exactly. There's a lot of questions that we're getting from your counterparts at health systems around the country, just around this rural hub and spoke strategy. So I'm thrilled that you're with me today to provide some inside baseball. I love to kind of start basic, high level. In your own words, can you just tell us what the hub and spoke model is?
Well, let me just start by saying how we started into this project, because, Robin, I think it might be interesting to people. About 2 years ago, Jim Weinstein, who is he's a vice president at Microsoft Health, the former CEO of Dartmouth Hitchcock, who also serves on the Intermountain board. He's been an advisor to Bill Gates and Gates Ventures for many years, and the concern around rural health is one that many of us have had for a long time. Rural healthcare is degrading quickly. Hospitals, particularly critical access hospitals around the country, are really struggling, and the care models, the disparities are just growing. In fact, in many areas, the disparities have tripled over the last few years. For example, you have 2% of people with cancer in urban settings die, but it's 15% in rural settings. You have just massive disparities that are growing, and that's just in one area. And they're really across the board. We've seen a degradation in healthcare in rural settings. And so Jim reached out to me and said, "Look, we've got to figure out what to do to help stabilize rural healthcare. Are you interested in kind of leading, a project here?" And I said, "Jim, like, if you were going to make a list of all of the 100 things that Intermountain should be focused on, kind of figuring out how to solve rural healthcare for the country is probably not on that list. But if we brought the right folks together and kind of really started with really understanding the problem, then maybe we could do something." And so Gates Ventures stepped forward, as well as West Health, to help fund um, really research into this area. So we hired the Boston Consulting Group and started looking into, let's really dive deep on all of the challenges surrounding rural health. So we really spent a good solid year studying the problem. And of course, from there, we said, okay, we don't just want to publish a paper. What can we as a coalition do to really advance, um, to really do something, not just wait for government to fix things, but maybe figure out a model that might help. And one model that we had been exploring at Intermountain, actually not exploring, but deploying at Intermountain for some time, is this virtual hospital concept that's really built around a hub and spoke model. And we realized years and years ago, in settings where we have 12 rural health facilities that Intermountain supports that are part of Intermountain. And we realized many years ago that with our obviously, we own Select Health, which is our insurance company. In settings where we had a rural hospital and we had somebody on Select Health, it just didn't make sense to transfer somebody that we could treat locally to an urban setting. And so we started developing hospital to hospital telemedicine programs, and then really brought dozens of these programs under one, what we call a virtual hospital. And it is a support model, a clinical support model that we offer rural hospitals, starting with our own, that has allowed patients when they come into a rural setting, if we're able to keep them there, we can really dramatically upskill the care delivery in those settings using tertiary and quaternary specialists who are remoting in with the doctors on hand. And what we found over time is we were able to avert between 15 and 18% of transfers from rural settings to urban settings. And that is a very big deal. The
Mhm.
thing, our hypothesis about how to stabilize rural health, Robin, starts with we have to stabilize things clinically. And I think the model, you've seen this kind of this great sucking sound of patients out of rural settings into urban areas because the level of care that you can get in urban settings is often better because you have tertiary and quaternary specialists you can consult. And we just realized with the capabilities around technology now, we could actually put those experts in the room with doctors in rural settings and improve patient care. Now, that has a compounding positive impact because it keeps the
Mhm.
patient local. It's obviously better for the patient. But our doctors, tertiary and quaternary specialists, are able to document and code in the electronic health record of those rural facilities, which allows them to better get paid for their services. And so there's a positive financial aspect to this as well. Not only, again, does it improve patient care, patient outcomes, but it's also helped stabilize the economics of these rural facilities. So this virtual hospital concept is one that we now support about 40 other critical access hospitals in our area, even up into Alaska, using this model, and we charge what we call a fractional resource model. It's unlikely that these rural facilities could ever pay for, in fact, they will never be able to pay for and staff these tertiary and quaternary specialists. But if we can allow them to pay for a fraction of that, really a marginal cost model, what it's made is these services affordable for these rural hospitals. And for Intermountain, it's largely a break-even proposition.
Okay.
But what it's allowed us to do is better titrate the demand and the pressure on our inpatient facilities in urban centers, which are becoming more and more strained by an aging population. So it's been a positive thing. So long story short, Robin, this hub and spoke model is really a clinical first model
Mhm.
about how do you stabilize things clinically that has positive externalities on the financial sustainability of these rural facilities. So we spent a lot of time looking at that. We announced this coalition, and this our first hypothesis is that maybe this is a model that other health systems might be able to replicate around the country, and we might be able to create an overlay for rural health, particularly critical access hospitals that can better improve their ability to take care of patients while improving their financial performance. But Intermountain doesn't have the resources or um, the depth of bench strength with our tertiary and quaternary specialists to serve the entire country. But there are many health systems who do have that concentration of expertise that we're hoping to share what we're doing so that maybe they could replicate the model. So that's a long answer to your question, but that's what we're up to.
No, that's fantastic, and that gives me a lot to dig into. I mean, one thing you briefly mentioned the white paper you co-authored with some of the coalition, and I thought it was a fantastic white paper. There were two things that stuck with me, and I think this hits at what you've outlined around the clinical and the financial benefits. So the clinical piece, as of January 2024, more than half of U.S. rural hospitals no longer offer maternity care, which is terrifying and fascinating, and then 2, that rural hospitals are running on 33 days cash on hand, or at least they were then. And so to me, this seems really, really powerful, in terms of a model. You've talked about this, a little bit, but can you sort of outline, what was the path that year that you said that you started to have these discussions? Were there other potential models that you considered in terms of trying to solve the rural health challenges?
Yeah, so Rob, when we looked at multiple models, and I think the model this is we are iterating on a hypothesis. This is certainly not fully baked. But our hypothesis really was born out of direct experience looking at those hospitals that Intermountain is supporting through our virtual hospital. We
Mhm.
spent a lot of time with those standalone critical access hospitals themselves. And, one of the areas one of the most popular services that we're offering is just critical care support.
Hmm.
And And so staffing a hospital, rural hospital, and having the expertise you need to handle a crisis, just having this overlay, this backup support is really, really valuable. And it helps signal to the community that these critical access hospitals are quite capable in solving problems. Let me give you one example. Um, we had last year a critical access hospital we support in Alaska had a 35-year-old male not walk in, come into the facility with a stroke score of 32 on a scale of 1 to 40. He was in a full-blown stroke. We were able to immediately bring in our telestroke experts into the room with the clinician via telemedicine. And that patient, their door to needle time to get the clot busting drug into their body was faster than you could get at any other academic medical center in the country. 8 hours later, that patient walked out of that hospital without a deficit. They would have had to fly for 3 hours to Seattle or somewhere else to be cared for, and they would have either died or had permanent brain loss. And we were able to save that patient's life. Maybe we don't know if he would have died or not, but certainly saved his quality of life. So it was an incredible outcome for that patient. What was also important was that it was a great day for that hospital, A, because clinically they were able to meet the needs of somebody in their community immediately. And B, it was our doctor documenting and coding in their electronic health record the treatment, the codes, everything else we did. And it was a great day economically for that hospital because they could also be bill and be paid for appropriately for that care. That's the power of this model. So you think about support models for a mother delivering a baby at a critical access hospital with neonatal resuscitation support from Intermountain Health, with the hands in the room being the hands of the doctor on duty, but the expertise coming from a neonatal resuscitation expert who is coaching that doctor what to do with that patient and with that baby. That is quite a powerful model. And so yeah, you see closures. The alternative is to magically create a bunch of additional doctors and nurses and have them show up in rural settings. But a full quarter of the doctors and nurses that are supporting US healthcare right now are in the baby boom cohort. They're leaving the market by 2030. And so the access problems, if you're relying on doctors being located everywhere, are going to get way worse before they get better. So models like this are going to be the models that have to emerge to solve an access problem. And gratefully, technology is at a point where we can actually effectively provide this care. Again, we've got competent hands in the room with the patient, supported by expertise that can come from anywhere in the country. And that's the model that is most hopeful. So, Robin, for us, the reason why we focus there is it's something we felt like we did not need to ask permission to do. Now, there are a whole bunch of other policy mechanisms that how is this paid for? How does it
Right.
work? Um, in many ways, it's already working for critical access hospitals are seeing the value in this fractional resource model that Intermountain deploys. But also, there's a lot of opportunities now to engage with policymakers about how do we better stabilize this idea. And so that's those kind of the next steps we're working on with this model.
Well, that actually brings me perfectly to my next question, which was around advocacy work. And I'd love to hear a little bit more just about the coalition in general. You mentioned Microsoft, Gates Ventures. Would love to hear about the other partners. And then could you outline us the five guiding principles as well? Because I really liked that as part of the white paper.
Well, there's a lot here, and let me just say we've been really pleased with our with our partners. I mean, Gates Ventures, West Health, Microsoft, and then towards the end of this work, we actually really effectively engaged with Epic as well. And if you think about the broad overlay, Robin, there's also a significant technological gap that rural health systems are struggling with. Oftentimes their technology is behind. Cybersecurity is a major issue. There's been the Department of Health and Human Services revealed that there's been a 250% increase in data breaches and a 264% increase in ransomware attacks. Some of the vulnerable points are these rural critical access hospitals who are already on their heels, financially. And they this idea of partnering with a Microsoft and with an Epic to look at options that dramatically improve the cybersecurity of these organizations, but also improve their access to electronic health records. Those are the next frontiers of what we're working on with this coalition. Is there's got to be a less expensive, easier to adopt pathway into a technological future for these rural hospitals that heretofore has been unavailable. So we're working around the edges of that. I'll just give you an example. Our clinicians today who support our rural hospital are maintaining, on average about 15 different EHR logins into different systems.
Wow.
And so it's very, very complex if you're trying to issue a standard order set for, a stroke. Trying to navigate a whole bunch of different EHRs is very, very tricky and confusing. So we think there may be some options to work with Epic and Microsoft to create an easier pathway for rural hospitals to adopt new technology, and that can also help things clinically normalize and stabilize what our clinicians are doing in these systems, and also help improve the revenue cycle operations of these hospitals, many of which are just can't get paid, can't figure out how to actually get paid.
Yeah.
And so those are some of the areas, the edges of what we're doing right now and exploring. Is there a way to do this holistically? So, Robin, speaking to the five principles guiding principles of this rural health work, we focus on these five things. One, solutions should be anchored on the critical health outcomes for rural Americans and keep them close to home. I mean, that disparity clinically is so important to address. Second, the solution should impact the operational sustainability of rural institutions, particularly critical access hospitals. If we lose these hospitals, then then it's just really hard to kind of bring back the infrastructure you need to take care of a community. And there are roughly 700 hospitals, critical access hospitals, that are operating with less than 30 days of cash on hand or really kind of hand to mouth. The third guiding principle is that the primary lens is rural hospitals with the surrounding health infrastructure as a secondary lens. Again, that focus, if you lose the anchor institution in a community, all the secondary institutions end up evaporating. The fourth principle is that, we want to the impact of our pilots need to address these challenges, and they should demonstrate a scalable potential within 2 years. It's one thing to go and fix one issue in a particular community, but if the solution isn't scalable, then we've missed an opportunity. And then the fifth area is that successful interventions will need to be actionable initiatives that this coalition can advance. And if you think about that, what we're not saying is we're waiting for a regulatory solution to start the work. What we wanted to focus on is the ability to just start acting, believing that if we are acting and working in this environment, then policymakers will have something to react to and help us with. And just given, some of the experience that I've had in government, it's always easier to for policymakers to build on the momentum of something that's existing natively in the ecosystem. So those are the principles. Again, you think about this. Are there other ways to go about this? Of course there are. Of course there are, and we're not saying that we have the unique, um, you know, domain knowledge here that says we have everything under control. But our hypothesis is that if we can stabilize critical access hospitals, if we can focus on scalable opportunities using these partnerships with I think some of the strongest and best solution providers like Epic, like Microsoft, we may be able to do something unique here in the space.
Yeah. Yeah, that's fantastic. There's a couple questions I want to ask in follow up. One is just around the actionable initiatives. And I like the fact that you said, we aren't waiting around for regulatory solutions. But, having said that, so much of policy, if I'm thinking about, reimbursement, as you mentioned earlier, technology, is impacted by policy. So, what type of advocacy work or how are you all thinking about kind of pursuing those lanes to make sure that the policy that is in place is kind of ripe to make this flourish?
Well, we're working very closely with the Trump administration. We were working closely with the Biden administration as well. The thing about rural health is it is a single issue. Um, we're trying to stabilize rural health care. And in so doing, we found on both sides of the aisle keen interest. I mean, you have rural areas of the country in red and blue states, and what we're trying to do, I think, has resonated well with policymakers. Much of what we need, frankly, is on the CMS side. It's working with CMS to say, okay, are there models that payment reimbursement models that might help reinforce this work? Now, Intermountain has been doing this. We're not we're certainly making it work for ourselves. It's not a great moneymaker for us, nor do we expect it to be. But there are enough incentives for us to try this out and to develop this, just in trying to ensure that if rural hospitals collapse, all that volume comes into very stressed,
Yeah.
very busy hospital systems who are getting busier by the day. So we need these rural hospitals to be successful in their work. And so there's a strong incentive for Intermountain to do this anyway. I think it's also a strong incentive for rural hospitals to participate because there's an economic model that drives it for them. But if there are opportunities to reinforce that model, for example, if there's additional, reimbursement that can go to these rural hospitals to help upgrade their infrastructure, their technology infrastructure, to help them move to um, newer and up-to-date electronic health records. If there's ways for us to support federally a cybersecurity blanket for rural hospitals, there are a whole bunch of different things that policymakers could help us do, and CMS could help fund. And it is not billions and billions of dollars. It is hundreds of millions perhaps, but it's spread
Mhm.
across the country. It is not a massive investment that is required to help upskill and stabilize rural hospitals. Um, we just need the patients to stay local. If they can stay local, the economics in the system should help support these rural hospitals. So we found actually very positive responses from both the Biden and the Trump administrations, even with Dr. Oz. I don't know if you mentioned if you saw this, but in his Senate confirmation hearings, he mentioned a little bit about the rural health work that Intermountain, Microsoft, Gates Ventures, West Health, and Epic are engaged with, and we find that very encouraging. So we'll just keep leaning in and doing what we can do on our own and looking for ways to partner with policymakers who really do care about these communities and are looking for good ideas. And we think this is a good idea.
You may have found the one of the few bipartisan issues that we can all kind of come to the table and work on. Um, I wanna talk about scalability as well, and just kind of where you are in terms of rolling out, and then anything else you can sort of share around this fractional resource model. I'm just thinking today's April 7th, 2025. I think once people are listening to this, they'll understand what that means. So I'm assuming there's going to be a lot more interest in this type of model, particularly with these small CHAs, or CAHs, I should say. So I'm just curious how far have you guys gone? You mentioned Alaska. Can you give us a sense of the geographic map at this point?
Well, Intermountain's virtual hospital supports the Intermountain West, and again, there are many people that are doing telemedicine programs, hospital to hospital. What we found in our model is that organizing it systematically and having standards of support have really helped us. And um, uh, if you think about it, there are we have a large academic medical center, Intermountain Medical Center, which is one of the top places in the country to get a whole bunch of different tertiary and quaternary care. What we've done is the fractional resource model is essentially we staff shifts in our virtual hospital with expertise from that medical center. So we have, stroke specialists and neonatal resuscitation specialists who come and take 8-hour shifts, 24 hours a day, 7 days a week in a virtual environment. And so if the more nodes that you have plugged into that, the more spokes that you plugged into that hub, the more efficient you can be in using and leveraging that expertise. And so the marginal cost of that for a critical access hospital who might see 2 stroke patients a year, you don't charge them for 200 stroke patients, you charge them for 2. But you
Mhm.
come up with a model that gives some baseline funding to cover that marginal cost of that staffing. And then again, the more nodes you have plugged in, the more scope or spokes you have plugged in, the more efficient you can be. That is it. And we're not overcharging, we're not trying to drive, we try to cover the marginal cost of the program. But what we're also doing is we're actually supporting our own urban hospitals with this model too. In fact, we found that our ability to deliver care at Intermountain Medical Center, which is across the street from where our virtual hospital resides, has also improved our care there because sometimes in a large academic center, it's hard to find a specific expert real time. Well, we tap into our virtual hospital there as well. So if you think about scalability, there are large academic institutions that have a concentration of tertiary and quaternary specialists around the country that could replicate this model, that could staff it in a similar way and extend services in a similar manner to rural hospitals in their area. And
Yeah.
so, are there hundreds of these? No. Are there a couple of dozen? Yeah, we think there are. We may need 10 or so hub and spoke models to really stabilize all of rural health. And I think what Intermountain's trying to do is just to say, hey, here's what we're doing. Let us share it all. We're engaging with the interested parties. They've reached out. We've had dozens reach out. We're working on creating a convening of folks who are interested in solving these issues, not just health systems, but also philanthropies. We think
Oh,
there's a unique
interesting.
role for philanthropy to step in and help initiate some of the funding to get these programs off the ground.
Yeah.
Um, but this is not something that Intermountain or anybody should really own. It's a if you think about this, we're really trying to create infrastructure across all of the United States that can help stabilize rural health. You do not need to actually create an ownership model that that you know requires a payout one day. I mean, ultimately, the most of the systems involved in this are nonprofit systems, and if there's a way to create something that is extensible, it'll be good for every community we can touch, and that's what we're trying to do.
Yeah. Yeah. I want to touch a little bit on the clinicians and the physicians and the nurses and all the folks that are part of this model. How do you train and support? Are there special things that you have to undergo? And I'm curious how the sets of physicians that are involved kind of work together around this too.
Well, I mean, there's no substitute for getting into a routine working in this model. I mean, it is somewhat new in the sense that, somebody all of a sudden is in the room with you
Yeah.
and saying, okay, here's what we're seeing, here's what you might consider doing. But in some ways, it's also familiar for doctors. We're counseling together with each other all the time. Our clinicians counsel together. What's amazing is that we're able to bring expertise right into the room. The cameras are so much better now. The diagnostic tools are consistent. You can really um, in fact, you talk to our neonatal resuscitation doctors, one of our doctors says I actually do a better job of neonatal resuscitation remoting into an environment because the cameras that we use on the bassinets, I can actually see the movement of the baby's chest better than when I'm in the room looking down at the patient because I can see across the chest of the infant. And so in some ways, we think our care is actually better than maybe even having the expert in the room. But there's no substitute for just building the clinical relationships between rural doctors and the specialists who dial in, and that is just comes from use and uh, being them in the moment with each other and solving the patient. The good news is that for the most part, that's worked really, really well. There's a patient in front of two clinicians, and they're counseling together how to treat the patient. That's a model I think that everybody understands and can get on board with. Um, but as far as advancing how this work should move forward, we certainly have the models we deploy at Intermountain. But I'm certain that a broader coalition, we will get better and better with this as we share amongst the health systems what we're doing. And that kind of a clinical program type model, we are anxious to learn from other health systems, to share what we're learning, and to learn from our sister organizations around the country. We think that the more we engage, the better the care will get.
Mhm.
And so, our intention is to share everything we're doing, be open about it, and then hopefully find, additional ways to improve the care delivery as we go along.
Yeah. Yeah, that's helpful. You mentioned earlier, the decrease in patient transfers of about 15 to 18%. I'm curious, what other clinical outcomes or metrics are you seeing or are you tracking as part of the model?
One of the things that we actually have been very, very pleased with, and I think it's hard to tease this out of the actual clinical results, but we're certain this is positive. For the patients who do need to be transferred, if you've picked up the care delivery from the moment they came into a critical access hospital emergency room and they do need to be transferred, the care delivery continuity across that transfer and when they arrive at another facility, whether it be an Intermountain facility directly or a level 2 or level 1 trauma center closer to where the patient is, the continuity of care that is facilitated by virtual hospital, um, we know is having a positive impact. We've been doing this routinely across most of our transfers, and we Intermountain is in the top decile for safety and quality in the country. We're really good at what we do. It's hard to tease out exactly how this program is helping us do this because we've been doing it for so long, but we absolutely believe it's tied into our clinical outcomes as well. When those patients arrive at our facility, we, at the very minimum, have documented and coded the level of of their complexity as they come into our facility, and we're able to again provide constant care across that journey. There's huge value in that, and we will one of the areas we're exploring is how to actually tease that out objectively through clinical research. But it feels like a no regrets move. How much that has improved our safety and quality is unclear, but we're confident that it has.
Yeah, absolutely. And I can only imagine, a well-managed patient is going to be a happier patient as well.
Yeah.
So happier clinicians too. Is there anything that surprised you so far, good or bad, as the strategy has rolled out? Anything that you just didn't anticipate or that worked better than you thought or
I haven't been surprised in a negative way in anything. It's been all
right.
been positive. And I think what I've been most pleased by is just a willingness from philanthropy and from large tech companies like Microsoft to say, let's find ways to iterate together on something that's meaningful that we can do today. Again, Robin, I think we look to government far, far too much to solve our problems. Um, I've been in government. I served in the Utah State
Yeah.
Senate. I deeply respect those from all sides of the aisle, both sides of the aisle, who are. I think the vast majority of those folks are trying to do good as they see it, and we see all the froth and blubble and the concern, and sometimes mistakes get made, but usually they recover. Um, but what I found is that we w those folks don't have any better ideas than people who are engaged in this day in and day out, and I think the real innovation that happens in healthcare happens because you get focused on a particular issue and think, okay, what might we do about this? And not create, I've got to have all of these things first to make it work. It's how do we do the next right thing that's within our control to do? And what I found that's been so pleasing to me was when you start with that mindset, you find things that you're able to do and to create new coalitions and new partnerships that nobody had conceived of before. And I honestly think that's how economies change. That's how markets change. That's how care models change. Just focused people, good people, asking questions, and really thinking about the long term positive societal benefit. That's what was the genesis here. And again, I just love and admire Jim Weinstein for coming forward and saying, maybe there's something here and maybe I can get Intermountain involved. And we're really grateful he did.
I love what you said. Well, so many things that you said, but the next right thing in our control to do. I love that. That's actionable, it's proactive, it's positive. Is there anything else that I didn't ask you that you feel like is a critical piece of this that our pod listeners should hear?
Maybe the last thing I would sum up, and I hope that all of my colleagues, and again, I'm so grateful for the Health Management Academy. Just so it's just amazing group. And so we don't lean in to very many organizations. This is one we lean into partly because um, it's it brings together the systems of stature through this country and brings them together in a meaningful way. And it is a organization that we learn and share through. Most of our health systems, in fact, all of our health systems are assets that can't be replicated or at least easily replicated. The problems we have in an industry are going to have to be solved by the industry itself. There's no, white knight showing up. There's no cavalry showing up.
Yeah.
It is going to be us. And I hope that that's what people will take away is to say, okay, if it's going to change, it really is going to require us to figure out how to change it, and to do it in a way that maybe this health system will be stronger and more resilient 10 years from now than it is today. And so I think that's worth spending our time on. I really think it's worth, certainly worth the chief strategy officers, the finance leaders, the CEOs spending time thinking down the road about what might we create. This is an industry that is going to go through tremendous turmoil over the next few years unless we change the delivery model deliberately. Then I think ultimately we could hurt a lot of people. And so just think taking that level of accountability personally is what we need the health systems to do. And I'm very optimistic that there's really not much we can't positively impact if we're working together more collaboratively.
I love it. That's a perfect place to land. Well, we at the Academy are very grateful that Intermountain leans into us. We are very grateful for you taking the time. I know you're an incredibly busy person, so we really appreciate you taking the time to unpack the rural hub and spoke model for listeners of our Health Systems CXO podcast. Thanks so much.
Good to be with you, Robin. Thank you.